Stroke. What should chiropractors know? It's important for chiropractors to be acquainted with what stroke represents with regard to cause and presentation, not only because of the implication that it may be related to manipulation, but because stroke is not one entity. The stroke that has been studied in relationship to manipulation is a very rare type of stroke, both in anatomical distribution but also in underlying cause. If no distinction is made, it might be assumed that the prevention of stroke in general, or the detection of risk for stroke in general, is the same for this distinct type of stroke related to the cervical arteries, most often the vertebral arteries. If the main cause of vascular risk in stroke, atherosclerosis, and the associated concern of hypertension were the only factors to consider, then prevention would certainly be a target goal. When vascular weakness, unrelated to these two factors, is the main feature, the goal of detection and prevention are likely unattainable. So let's begin with a broader review of stroke and attempt to answer the following questions. What is stroke? What are the different types of stroke? Are risk factors and preventive measures the same for all? What are the potential warning signals of impending stroke? Are there clinical tests to detect stroke before it occurs? What are the indicators of dissection? What are the indicators of stroke? What should be done if stroke occurs? And most importantly, is there a cause and effect relationship between manipulation and vertebral basilar stroke? The use of the term stroke is not consistent. There are a number of vascular events that can occur which are not always included under the discussion of stroke. By definition, stroke is an acute onset of neurological deficit that is vascular in origin and lasts at least 24 hours and is reflective of a focal involvement of the brain that may then manifest as diffuse neurological deficits. That would mean that shorter events have a different terminology, and those events that are more diffuse in damage also have a different categorization. A transient ischemic event, or TIA, represents an event that resolves by 24 hours after onset, often in the first 30 minutes. It does turn out, though, that 1/3 of patients who have TIAs will have a stroke over the following 5 years. Reversible ischemic neurological deficit, or RIND, also called a minor stroke, is a term used for those events that fully recover but take longer than 24 hours, often over 3 days or so. One important point is that TIAs and RIND represent ischemic events and not hemorrhage. Other cerebral vascular events that are more diffuse and do not classically fit under the definition of stroke are termed global cerebral ischemia, usually from cardiac arrest, or subarachnoid hemorrhage, which is usually from a ruptured Barry aneurysm or arteriovenous malformation. Our role is not to diagnose the specific area involved with stroke, but generally with stroke, it is possible to determine the side of the brain involved based on motor or sensory deficits, which are generally on the opposite side of the body, and aphasia, which would indicate the left side of the brain. Further distinction is based on whether it is the anterior or posterior circulation that is involved. The anterior circulation is from the internal carotid and its branches, and it includes the cerebral cortex and subcortical white matter, basal ganglion, and the internal capsule. The posterior circulation is primarily the cerebellum, thalamus, brainstem, and parts of the occipital and temporal areas. The supply is from the vertebral arteries, the branching basilar arteries, and their branches. Signs and symptoms are related to brainstem dysfunction, including coma, drop attacks, vertigo, nausea, and ataxia. Let's first start with the more global damage syndromes before moving on specifically to stroke. First, subdural hematomas. These are more common in seniors and are due to trauma, often from a fall and hitting the head, which shifts the brain in relationship to the skull, causing shearing and tearing of the bridging cortical veins. These veins are low-pressure vessels, so that although symptoms are often immediate, they may take days to months to develop. Patients with head trauma should be monitored closely for the first 3 days, regardless of whether consciousness is lost or not. Persistent headache, slurred speech, clumsiness with walking, or changes in mood warrant further investigation. Hemiparesis, when present, is almost always contralateral, whereas pupillary dilation is ipsilateral. Epidural hematoma is also due to head trauma, usually associated with a skull fracture, often a temporal fracture, tearing the middle meningeal artery and vein. There may be a lucid period of a few hours before lapsing into coma, so it's unlikely we will encounter these patients in practice, but it does again call to our attention the need to have any patient with head trauma monitored closely. So for both of these non-stroke but brain-damaging vascular conditions, what is the key distinguishing factor? Head trauma. One of the causative factors of brain damage with these two conditions is increased intracranial pressure. Let's consider the three components confined by the bony skull: the brain, blood, and cerebral spinal fluid. If any of these elements expands, permanent damage and death may occur. We know that for brain tumors, they tend to grow slowly with slowly developing neurological signs and symptoms, often without head pain. Pressure effects from blood are the most important features with subdural and epidural hematomas, and with trauma and infection, increases in CSF are a concern. In review then, tumors are slow-growing so that symptoms are slow in onset, whereas edema and hemorrhage, either spontaneous or trauma-induced, cause a more acute onset of symptoms. So now stroke. How common is it? It's the third leading cause of death in the U.S. It is important to understand the different types of stroke. The first type is thromboembolic or ischemic stroke, which represents occlusion or blockage preventing blood from reaching its target tissue. The second type is hemorrhagic stroke, which represents bleeding due to a rupture of a blood vessel or vessels. Further categorization includes the two major types and one combined type: hemorrhagic, intracerebral or subarachnoid; ischemic infarction, which is either thrombolic or embolic. These are the two we just discussed, and also a third type where infarction may lead to hemorrhagic conversion because the blood vessels become fragile and rupture. Let's start with thromboembolic stroke. Some definitions. An embolic infarct forms distally and travels to the brain. A thrombolic infarct usually is caused by a blood clot forming locally, usually due to atherosclerosis. Generally, embolic stroke occurs suddenly with rapid onset of symptoms, whereas thrombolic may be slow to develop. Stroke events that have the same clinical signs each time are generally from the cerebral circulation and are more often thrombotic, while those that differ are often cardiac in origin and are embolic. Some generalizations about infarcts are that large vessel infarcts generally occur from emboli. Small vessel infarcts include small penetrating vessels to deep structures such as the basal ganglia, thalamus, and internal capsule or the brainstem. Small vessel infarct is sometimes referred to as lacunar because they form small cavities. Specific lacunar syndromes have been identified with associated neurologic signs. Having many small infarcts is a common cause of not only motor and sensory deficits in the elderly, but also dementia. A sudden onset of what looks like Alzheimer's may represent multi-infarct dementia when associated with sudden onset of sensory or motor deficits. So where do emboli come from? Some come from the heart. They're called cardioembolic. Among other potential causes, 30% of patients who have electrocardioversion for arrhythmias throw emboli. Depending on the type of dissection, emboli may also occur. A patent foramina valli, if you recall, is a congenital atrial septal defect. It's associated with emboli and may have a relationship to migraine headaches. Deep vein thrombi more commonly travel to the lungs. Other causes other than thromboembolism are air, fat, and septic emboli. The most common non-traumatic cause of intracerebral or hemorrhagic stroke is chronic hypertension. Symptoms are caused by compression of adjacent tissue, which then may produce ischemia. Hemorrhagic stroke tends to cause more severe headache and neurological depression than ischemic stroke. Neurologic deficits do not correspond to any single blood vessel. A more focal type is subarachnoid hemorrhage. It causes increased intracranial pressure and toxic effects of subarachnoid blood on brain tissue. Vasospasm also occurs. Extension of blood into the brain can occur with associated hydrocephalus. Subarachnoid hemorrhage usually presents as headache rather than neurologic deficits. It's often meningeal in appearance with positive dural signs such as Brzezinski's with or without fever. 75% of cases are due to a ruptured barrianeurysm, while 10% are due to arteriovenous malformation or AVM. Most of these entities are basically ticking time bombs in an individual that presents suddenly without any warning. Now let's speak specifically to vertebral basilar ischemia mechanisms. VBI may occur spontaneously or due to trauma, sometimes relatively minor trauma to the arterial wall, causing damage and or vasospasm. Here are some results. Subdural hematoma, intimal tear with or without emboli, dissection with subintimal hematoma, dissection with pseudoaneurysm development, and perivascular bleeding. Remember that vascular health is not only what is already present in a patient, but in addition, what can develop over time. Let's first address the most common cause of ischemia, atherosclerosis. Here are examples of structure and result. In the brain, thromboembolic stroke. For carotid and vertebral arteries, subclavian steal syndrome or embolic stroke. For the heart, angina and myocardial infarction. For the lungs, thromboembolism and possible infarct. For the aorta, occlusion leading to intermittent claudication. For the abdomen, splanchnic infarct leading to pain and possible death. For the renal arteries, stenosis leading to hypertension. And for the peripheral vasculature, peripheral artery disease leading to intermittent claudication. Now the other side of the coin, vascular weakness. We have three main considerations. Aneurysm, which is a dilation of a blood vessel. Arteriovenous malformation, or AVM, which is a congenital tangle of arteries and veins that affects about 1% of the population, but only about 20% of them develop problems, usually before the age of 40. And dissection, which is a tearing, usually sudden tearing, of the inner lining of the artery. This may overlap in a condition called a dissecting aneurysm. Now, looking at these two potential causes of stroke, atherosclerosis or vascular weakness, can we address risk factors? Well, for atherosclerosis, of course, we have high cholesterol, diabetes, obesity, smoking, and lack of exercise, all modifiable. But for age, gender, and familial history, we realize these are non-modifiable. For vascular weakness, the only risk factor that is modifiable is hypertension. The other risk factors are not. These include genetic causes, inflammatory vascular diseases, connective tissue weakness, and collagen vascular disorders. In addition to risk factors, are there other history clues for atherosclerosis? Well, certainly a past history of angina or MI or a presentation of angina with chest pain relieved by rest are helpful. Vascular claudication is indicated by signs of pain in the lower extremity brought on by walking and relieved by rest. Renal stenosis is indicated by a recent increase in hypertension even when on antihypertensive medication. And amaurosis fugax is indicated by transient vision loss, often described visually as a curtain being pulled down. This indicates carotid artery blockage with subsequent emboli to the retinal artery. There are also some physical exam opportunities. We can auscultate for bruits in the renal area and in the neck for the cervical circulation. We can also perform an ankle brachial index for peripheral vascular disease, and certainly taking blood pressure for hypertension. We're now going to focus on dissection. We know that about 80% or so of individuals who have vertebral basilar stroke report symptoms at the stage of dissection. These include headache and neck pain. How would we know if a headache is due to dissection? We know that headache and facial pain account for approximately 13% of complaints seen by chiropractors according to the NBCE Practice Analysis Survey data. So we know we have to deal with this potential indicator of dissection. Let's use a couple of case examples. Here we have a 65-year-old female who presents with a complaint of headache. The headache is temporal in location. The headache is new. So what might the alarms be in this presentation? We generally would not be that concerned with a patient with a temporal headache. But let's look at this one. Our level of concern increases because this is a senior. Our level of concern increases again because she describes this headache as new. 90% of headaches, such as migraine, generally occur before the age of 40. And once again, our level of concern increases because we have a new headache in a senior with a temporal location. Here's why we're concerned about the location. Here we see the area of vertebral artery pain referral. And here we see the area of internal carotid artery pain referral. So our patient needs further evaluation, but statistically we can internally not be too concerned, given that studies indicate that only about 2% of patients in office and 4% of patients in an emergency room setting will be diagnosed with a headache indicating serious pathology. That doesn't mean, though, that she doesn't need further evaluation. One potential cause of this presentation is a condition like atherosclerosis that blocks arteries, but not with plaque, but more acutely with immune complexes. It's called temporal arteritis and can be screened using lab testing, including ESR and C-reactive protein. Medically, a biopsy can be performed at the superficial temporal artery. So let's review a red flag checklist. Trauma, nuchal rigidity, which may indicate both meningitis and subarachnoid hemorrhage, vision loss, which may indicate small or large stroke, any acute onset neurological signs and symptoms, and new headache in an older person. Let's try another case. This time it's a young person, a 21-year-old female with a 3-year history of chronic headaches, described as unilateral, but changes sides occasionally. There's also some nausea. And she states that when she takes 1,000 milligrams of aspirin, the headache goes away in a couple of hours. She calls them bad, but she is able to continue working as an administrative assistant. Again, let's build a case for or against being concerned. Our level of concern is decreased because she is a young patient. It's decreased further because these are not new headaches. And finally, her headache responds to medication. It's unlikely that if her headache is serious, it would respond to aspirin, but we'll see that there is evidence that this level of aspirin intake, 1,000 milligrams, is effective for many patients with migraine. So we're less concerned if her headaches are chronic because 90% of headaches are either migraine, cervicogenic, tension-like, or cluster, and most begin before the age of 40. Let's review these briefly, cluster headaches in particular, because although they are quite rare, they primarily occur in middle-aged males, often who are heavy drinkers or smokers. The pain is most often facial and orbital pain. The pain is severe and tends to cluster as multiple headaches a day over weeks that last an average of 30 to 45 minutes, but as long as 2 hours. The first time these occur, they are difficult to distinguish from stroke and require neurological evaluation. The presentation may include a temporary Horner syndrome, and this includes, as you remember, ptosis, meiosis, and anhidrosis. Migraine headaches are also severe and have two presentation types. Classic with aura, which accounts for only about 15 to 20% of migraine, and the common migraine without aura, which accounts for 80 to 85% of migraines. Here are the history findings for migraine and their occurrence. About 85% report a pulsatile headache, 75% report associated neck pain, 75% report associated phonophobia or photophobia and nausea. 50% report at least one of the following triggers: a change in weather, stress, lack of sleep or fatigue, and alcohol or food triggers. Migraines are commonly associated with other disorders, including psychological disorders such as depression, multiple sclerosis, Raynaud's, and Meniere's. Here are some surprising findings with migraine in children. Although in adults there is a clear female predominance, there is some evidence that under the age of 12, migraine is more common in boys. There is a gradual shift to female predominance so that at age 20, the female to male ratio is 2 to 1, and at ages 42 to 44, it is about 3 to 1. For migraine in children, about 20% of them report a visual aura. The aura is generally short-lived, being about 30 minutes or less. The description of pounding or pulsating is less common in children, as are reports of phonophobia and photophobia. Finally, headaches are generally shorter, lasting on average less than 2 hours. They may be more frequent, though, in children. Let's remind ourselves of some of the migraine theories. Dysfunction of brainstem modulation of sensory input is proposed as a major element of migraine and other headache pain. Remember the intracranial structures of the anterior and middle fosses above the cerebellar tentorium, such as large cranial blood vessels, proximal intracranial blood vessels, and the dura, are innervated by the ophthalmic division of the trigeminal nerve. Posterior fossa structures are innervated by cranial nerves 9 and 10, which may then refer to the ear or throat, and by branches off the C2 nerve roots, which may refer to the neck. Input from the trigeminal innervated structures pass through the trigeminal ganglion, synapsing in the trigeminal cervical nucleus. Information is then sent through the quintothalamic tract after decussating in the brainstem. The trigeminal cervical nucleus is the spinal relationship between the dorsal horn for the C1 through C3 area and the spinal nucleus of the trigeminal nerve. Misinterpretation and augmentation of nociceptive signals can then be found in either area of distribution. So what is a migraine aura? It's believed to be due to what is called a spreading wave of cortical depression, which is basically ischemia passing through an area of the cortex. The spreading depression wave progresses across the cortex at approximately 2 to 5 millimeters per minute. It's believed that increased extracellular potassium ion concentration and excitatory glutamate contribute to the initiation and propagation of cortical spreading depression. The aura is found in about 15 to 20% of migraine sufferers. Patients report visual phenomena, most often stars, flashes, sparks, and lightning bolts. This is followed by scotomas or blind spots. These scotomas tend to gradually grow and are often surrounded by scintillation, the term used for flashing colorful lights. These visual phenomena are likely reflective of hyperexcitability followed by neural depression. So what do you think this drawing represents? It's not a cubist sculpture on a farm, but a drawing of a phenomenon by a migraine sufferer that reflects a visual morphing effect seen with some migraineurs. This is actually a fence post that's been transformed into this image, which is not surprisingly taking the shape of what most migraine aura sufferers experience, the kidney bean-shaped scotoma. This publication in JAMA in 2006 is a review by Detsky. It looked at whether there were indicators that as a group might indicate that a patient has a migraine, or whether patients might have a serious cause in need of special imaging. From this study, an acronym and a proposed clinical prediction rule were developed. Clinical features indicating the need for neuroimaging included cluster-type headache, a likelihood ratio of 10.7, abnormal findings on neurologic exam with a likelihood ratio of 5.3, undefined headache, meaning it didn't fit the classification for cluster, migraine, or tension, with a likelihood ratio of 3.8. The first occurrence of headache with aura had a likelihood ratio of 3.2, and headache aggravated by exertion or a Valsalva-like maneuver with a likelihood ratio of 2.3. The acronym for migraine proposed by the researchers is POUND. The P is for pulsating, O is for a duration of 4 to 72 hours, U for unilateral, N for nausea, and D for disabling. If 4 of the criteria are met, the accuracy for diagnosing migraine is high and decreases with fewer criteria being met. Let's discuss some of the medications for migraine. Medication works in only about 50% of patients, and for those patients, only about 50% of the time. Medication may also be a source of headache pain. Medical management is divided into two types, abortive and prophylactic. For abortive, the drugs are primarily NSAIDs and triptans, which are serotonin receptor agonists. An example would be sumatriptan. Related to NSAIDs, this Cochrane review indicated there is some evidence that a 1,000 milligram dose of aspirin often relieves migraine pain over a 2-hour period, so our previous case who responded to this level of aspirin intake is unlikely to have a serious cause for her headaches. Note that many of these medications, mainly NSAIDs and triptans, can be a cause of rebound migraine due to taking medication for too long or suddenly stopping. A rebound migraine is often far worse than the original migraine, often causing patients to seek emergency care. Prophylactic medications include the antidrugs, antidepressants, antihypertensives, and anti-seizure medications taken at much smaller doses than for the treatment of the primary intended disorder. So now let's move on to dizziness. The distribution of causes for dizziness at a dizziness and balance clinic for patients over the age of 65 were that 32% was due to benign paroxysmal positioning vertigo, 22% was due to either fear of falling or disuse equilibrium, and only 13% due to vestibular loss. All other causes accounted each for only 5% or less of cases. When we look statistically at all cases of dizziness across all ages, the primary in order are benign paroxysmal positioning vertigo, or BPPV, Meniere's, and vestibular neuritis. All have a very sudden onset, and on their first occurrence may seem stroke-like. They are distinguished by time so that BPPV lasts for seconds to minutes and is provoked by head movement. Meniere's lasts for hours to days and is associated with low-tone hearing loss, and vestibular neuritis, which is constant, lasts for days to weeks with no hearing loss. So we can see that time plays a factor, and given these are often recurrent disorders, whether a patient has had a similar occurrence in the past is important. Assuming a patient can, on an initial occurrence of any of these causes, get to the emergency room during the attack, it would not be uncommon to then be tested with neuroimaging. Without getting too detailed, let's look at what governs our sense of balance. There are neurologically 3 systems that are integrated to provide balance: the vestibular apparatus, the cerebellum and its integration with proprioceptive input, and vision. And overriding all of these systems is the vascular supply to these structures. What is helpful is to take these systems and match them to patients' complaints. By clarifying a patient's complaint of dizziness, we can narrow down the likely neurologic component involved. If reported as the room spinning or self-spinning, we can designate this as vertigo and know that this is likely vestibular in dysfunction. If the patient reports the dizziness as imbalance when standing or walking only, we can be fairly sure that it is not vestibular but likely proprioceptive or cerebellar. If the patient describes a feeling like they're going to pass out, we can designate this as presyncope and know that there is likely a vascular cause. Here's another JAMA review that investigated who with dizziness to be concerned about. Here's a summary of their findings. A cluster of signs and symptoms is most beneficial. By asking questions, 60 to 75% of dizzy patients can be diagnosed. These include whether the dizziness is true vertigo or spinning, the length of episodes as we've seen, and whether there is hearing loss or not. Specific additional questions for BPPV include positional provocation. Specific exams for dizziness are beyond the scope of this presentation, but would include the Hall-Pike-Barani maneuver for BPPV and hearing testing for those with an associated hearing complaint. Let's now discuss intracranial arteries in contrast to most extracranial arteries. Histologically, the intima is a well-developed elastic membrane thicker than extracranial blood vessels. The media, composed of both muscular and elastic membrane, is far less substantial than the extracranial blood vessels, and the adventitia is thin and has no perivascular supporting tissue, no external elastic lamina, and no vasa vasorum. Anatomically, the path of the vertebral arteries is divided into 4 segments. V1 is the prevertebral segment, where the artery lies behind the anterior scalene and longus colli muscles prior to entering the C6 transverse foramen. V2 is the vertebral segment, passing through the transverse foramen of C6 to exit at C2. V3 is the atlantal segment, after it exits the transverse foramen of C1, and V4 is the intracranial section that proceeds to the pontomedullary junction. The artery is relatively fixed throughout the pathway through the transverse foramina. The 2 areas believed to be at risk for mechanical damage are the portion of the artery that travels out from C2 to reach laterally to enter the C1 transverse foramen, and the path at C1 where the artery passes through a groove behind the articular process before crossing the atlanto-occipital membrane and then into the dura, entering the skull. Let's do a brief overview of the evidence with regard to manipulation and stroke. Further discussion is presented in the Cassidy et al. Video. There is no scientifically sound evidence establishing a cause and effect relationship to cervical manipulation and stroke. There is strong evidence that patients in dissection present with severe headache and/or neck pain and should not be manipulated but referred to emergency care. So with VBI, it's not about prevention. It's not about diagnosis. It's about recognition of dissection, and it's about what to do when dissection or stroke occur. The type of stroke and reported cases associated with manipulation were not thromboembolic, but via dissection and subsequent occlusion from the dissection. Therefore, using tests that detect atherosclerotic occlusion will not help with identifying risk. We know that there are no clinical exam procedures that can detect dissection or the risk for dissection or reflexogenic vasospasm. We can look for the signs of dissection or stroke. With dissection, severe headache or severe neck pain usually reported as first or worse. And of course, for the stroke itself, the 5 Ds and 3 Ns: diplopia, dizziness, dysarthria, dysphagia, drop attacks and ataxia, nausea, numbness, and nystagmus. Let's summarize the role of chiropractic in relationship to stroke. Chiropractors recognize a distinction between general cardiovascular risk with associated complications of myocardial infarction, stroke, and peripheral vascular disease, and stroke that is not atherosclerotic, but instead is related to dissection or intimal tearing or reflexogenic spasm. This latter type is almost exclusively the cause of vertebral basilar stroke. Therefore, chiropractors use a holistic approach to education, prevention, and care related to cardiovascular risk associated with the development of atherosclerosis. However, given there is no established cause and effect relationship for any specific condition or mechanism for VB stroke, efforts are directed toward focusing more on the recognition of patients in dissection, and if stroke does occur, the protocols for managing that patient.